everyone, and welcome to Listen to Your Gut. My name is Amanda Hively, and I am a mom of twin boys who both have CF. I will be moderating the session this evening, and I'll be introducing our other speakers in just a moment. This session is also being recorded and will be available to all registrants after the event on the CF Foundation YouTube channel. You will be notified by email when session recordings are available. Before we get started with the session, I want to go over a few items related to the technology and how we can all interact. First, closed captioning is available. You can turn them on by moving your mouse over the video feed and clicking the CC icon that will pop up at the bottom of the screen. Under the Stage tab on the right side of your screen, you'll notice the chat for everyone who is in this session. If you are in the Event tab chat, that is for the full event and not specific to this session. So be sure you're in the correct chat to engage with others in this session. We will be taking audience questions during this session. We encourage you to submit your questions at any time into the Q&A box. You can find the Q&A by making sure you are in the Stage tab on the right side of your screen, then select Q&A. We will do our best to answer as many questions as possible. You can also like questions submitted in the Q&A by others, which will help us prioritize based on popularity. Make sure you use the Q&A box to submit questions, not the group chat where questions may be missed. We won't be able to answer questions about individual diagnoses or treatment plans, and we encourage you to use the information you learn today to have conversations with your care team. If you have any technology problems during the session, click the help desk icon on the left side of your screen. CF Foundation IT support are there to help if you are having any trouble during the event. There will also be a few polling questions from us panelists, which you will be prompted to answer throughout the session. These polling questions will help us get an idea of who everyone is and what you're excited to learn about today. Polls can be found on the right side of your screen next to the Q&A and chat. Now, I would like to introduce our speakers for today. We have Dr. Jay Freeman, Dr. Sarah Lussman, Dr. Nicole Green, and Dr. Daniel Leon. Next, we have the disclosures for all of our speakers. Now that all of that is out of the way, let's jump right into today's session.
Thank you, Amanda. Appreciate the wonderful intro. We're going to get tonight started off a little bit differently than many of our sessions with a little bit of a Q&A with Amanda and some of her experience with GI issues with her two young boys, Mason and Grayson. As she stated earlier, Amanda is the mom of twins with CF. So Amanda, can you tell us a little bit about the early experiences, especially how you first came to know that Mason and Grayson were going to have CF?
So we found out that Mason and Grayson had cystic fibrosis before they were born. At my 20-week anatomy ultrasound, it was discovered that both of the boys had echogenic bowels, and that's where the bowels show very bright on the ultrasound. Further testing was done, and when I was around 30 weeks, we got the call to confirm that both of the boys carried 2 copies of the Delta F508 gene.
So I know early in life there was quite a bit of GI distress, if you will, and a lot of the GI comorbidities that we often see with CF. Can you discuss how these GI symptoms and how they impacted the early life for your boys?
So it was very discouraging to watch our boys, especially Grayson, overcome one complication after the other. It felt like we were functioning in survival mode for the first 3 to 4 years of their lives. Because they were both born with meconium ileus, the boys spent the first 2 to 3 months of their lives in the NICU. And since then, Grayson's experienced about 15 admissions and multiple surgeries related to gastrointestinal complications. He has needed a feeding tube along with feeding and speech therapy to overcome certain obstacles. Mason has also had his share of complications. To hear doctors tell us repeatedly that what Grayson was experiencing was not typical, while also not knowing how to fix his problems, was very overwhelming.
Yeah, I can only imagine as a parent what that must be like. Well, you had all the GI symptoms and all of those frustrations, and then the promise of modulator therapies came around. And I can only imagine for you and your husband that was thought of as the cure for everything that was going to be great. But I do know that also with the boys, we had some issues with their liver enzymes bouncing around. Can you please talk about or can be modulator therapies and some of the frustrations you've had, especially with liver enzyme fluctuations?
Yes. So Mason and Grayson were put on Orkambi when they were about 3 years old. About 6 months into therapy, both of the boys had increase in liver enzymes. Mason's increase warranted him to come off of the medication. Since we didn't really see any relief of GI symptoms with Grayson, we decided to take him off of the medication as well. They didn't take another modulator until Trikafta was approved for their age group. This go around, Grayson had to temporarily stop the modulator. So he had to have more labs to monitor his liver function. He does well with labs, but it's still not pleasant. The speed bumps they have experienced with modulators is just a blunt reminder that despite having a common mutation, every CF case is different and responses to modulator therapy vary.
Absolutely. Well, one of the themes for ResearchCon has been really about being inclusive of everyone, and why I know Dr. Sawicki discussed, incorporating people from different backgrounds and making sure everybody is included in this path to a cure. Sometimes what gets forgotten is the other family members that may be indirectly impacted. I know you have an older daughter. Can you discuss some of the challenges of having not one, but two children with CF and then a child who's otherwise healthy and what that's like?
So we do have an older daughter. Our daughter Zoe is currently 10 years old, and she's absolutely been impacted by the boys' diagnosis. She was 4 when they were born, and she went from being an only child to dealing with 2 medically complex little brothers. She had to abruptly learn to share our attention, and she dealt with separation anxiety due to the boys' frequent appointments and hospitalizations. She had to learn at a young age that sometimes things just aren't fair. As parents, my husband and I, we try to make sure that we set aside time specifically with her. We don't ever want her to feel like she's been forgotten when the boys' medical needs have taken priority.
Absolutely. Thank you for that. Well, it's been 6 years, I guess, now with the twins and all the ups and downs with GI and liver issues. As we look for the future, what are you looking forward to as a parent for GI and liver research?
So I really hope that our experience with Mason and particularly Grayson echoes the need for further research and standards of care for GI complications within CF. Seeing more research studies geared toward the management of GI symptoms would be a welcome sight. I would like to see specific guidelines for the management of DIOS in the hospital setting and modulators that don't affect the liver as much. I'm hopeful to see continual growth in the research pipeline and am excited about the potential breakthroughs that haven't been discovered yet.
Excellent. Well, thank you so much for that personal insight, Amanda. And I think that sets the stage very nicely for our speakers to come. I'll turn over to you to introduce them.
All right. So now we have going to turn it over to Dr. Sarah Lessman for her presentation.
Thank you, Amanda, for that kind introduction and for sharing your family's story with us. I'm going to start off the next part of the session by talking about how we've been building a network of CF gastroenterologists. Our objectives for this section are to review the spectrum of digestive symptoms in CF, summarize what we already know about common symptoms, including abdominal pain, bloating, and constipation. We'll talk about the goals and the outcomes of the DIGEST program, and then finally identify some tools to improve access to CF gastrointestinal or GI care. Let's talk first about what happens in the CF intestine. CFTR regulates the flow of salt and water in and out of the intestine, as well as the pH, or the acid-base balance of what's inside the intestine. When CFTR isn't functioning, thick mucus can build up in the intestine in a very similar process to what happens in the lungs. This thick, sticky mucus can in turn lead to changes in the populations of bacteria that live in the gut, known as the microbiome, as well as chronic inflammation in the intestine. And then these changes in turn can affect the nerves and the muscles in the wall of the gut. We've known for a long time that abdominal pain is very common in people who are living with CF. Several studies, including this one that I'm showing here, have shown that children and adults with CF have undertreated pain and very commonly have pain within the abdomen. This study, which was done almost 15 years ago, shows that the abdomen was the most prevalent location of pain in children and the second most prevalent in adults. And for individuals who complained of pain in more than one location, the abdomen was always, almost always one of the locations. And so we know that recognizing and managing abdominal pain, as well as other types of GI disease and CF, is really an important part of comprehensive care. There are many reasons why individuals living with CF can develop abdominal pain and bloating. We've already touched on inflammation in the GI tract, as well as changes in the bacteria that live within the intestines. Sometimes you hear people talk about good bacteria and bad bacteria. And what that really means is that there are some bacteria, the good ones, that digest your food very efficiently, and others that don't. They digest it in a way that creates a lot of liquid and a lot of gas. And when these bacteria can grow out of proportion to the good bacteria, you get something called small intestinal bacterial overgrowth, or SIBO, which can develop symptoms of diarrhea, abdominal pain, and bloating. We also see changes in gut bacteria within the large intestine, or the colon. The accumulation of sticky mucus, as well as the changes in the bacterial composition of the gut, can cause retention of stool, constipation when stool builds up in the large intestine, and distal intestinal obstruction syndrome, or DIOS, which is when stool builds up in the last part of the small intestine. Individuals with CF can also have altered transit or motility, which refers to how food, gas, and stool move through the digestive system, as well as altered sensation. Motility was a big theme of ResearchCon in 2021. And I want to touch on it again because I think that this rings so true and so deeply for so many people. The nerves in the gut regulate something called peristalsis, which is sort of like the pacemaker of the intestines. These are contractions of the muscles in the wall of the intestine that keep everything moving. They propel food and stool through the gut from top to bottom. And these nerves are so important, they can really be impacted by changes in the gut bacteria, by diet, by medications, and all other things that are part of comprehensive CF care. Not only do these nerves regulate peristalsis or movement, but they also have a sensory function. They sense and communicate pain and discomfort to the brain that comes either from stretch in the intestine, distension from food, gas, or stool, temperature, heat or cold, as well as chemical changes like irritation from acid and inflammation. When CFTR isn't functioning and motility is altered, then this is how a lot of GI symptoms can develop. And so the motility, the movement through the intestine, can really be affected by the use of antibiotics, inflammation, changes in the gut bacteria, diet, blood sugar control for those who are living with CF-related diabetes, as well as dehydration. And this can affect multiple regions of the digestive system. For example, in the stomach, alterations in motility can lead to slow emptying or gastroparesis or very rapid emptying. In the setting of gastroparesis, individuals might feel full easily after eating just a small amount of food and may also have nausea, vomiting, and bloating. When transit within the small intestine is delayed, that can cause the sensations of gas, bloating, and nausea. And total GI transit, so the time it takes from when you eat something until it comes out, can really vary between individuals and in the same individual over time. And a lot of that is because, again, of the mucus and the stool that are lining the inside of the bowel wall, allowing more liquid stool to flow through. So it can be counterintuitive. Often people feel that they're going to the bathroom more frequently or that they're having diarrhea, but in reality, what's happening is that there's a lot of retained stool. And so what's actually needed is to treat constipation rather than diarrhea. And it's really important that you have a provider who understands this and can help you work through these symptoms. So now that we've talked about some of the most common symptoms and why they can happen, let's review how we're learning how to study these symptoms. In the GALAXY study, the team partnered with Community Voice to identify the patient-reported outcome measures, or PROMs, that most accurately reflected their experience with the GI symptoms in CF. The team also surveyed members of the care team to identify their comfort level in managing a variety of GI conditions. In designing the study, the team piloted the use of many different patient-reported outcome measures, or PROMs, and eventually settled on the three that I've circled here: the PAGI-SIM, the PAC-SIM, and the PAC-QOL. The PAGI-SIM, which is the one on the left, I know this might be small on some people's monitors, focuses a lot on pain, discomfort, as well as lower GI symptoms such as bowel movements and constipation. The PAC-SIM reflects more upper GI symptoms: abdominal pain, nausea, vomiting, acid reflux, and appetite. And then the PAC-QOL really focuses on people's feelings, their quality of life, and how these symptoms are impacting them on a daily basis. When the study was conducted, these PROMs were given to study participants electronically, known as EPROMs. And here, what the study team was trying to do was to see how feasible, how doable it was to have the study participants actually complete all of these electronic surveys. So here we're showing the pink bars, which show the data for pediatric patients less than 18, whose guardians completed the PROMs, as well as adult patients who are shown in the blue bars. And you can see here that after the first week, in the top box, looking at how many people fully completed at least one of the measures, they were over 80%. And at the end of the study, fully completing all of the measures, almost 78%. And these response rates are actually quite high for questionnaire-based studies. And this really speaks to the motivation of the patients and families who were participating in the study and how important these issues were to them. So the results of the GALAXY study have not fully been published yet, but what I can share with you is a summary of what was found. So overall, the women who participated in the study had higher or more severe total symptom scores than the men. And this is in line with studies that have been published about irritable bowel syndrome and many other GI disorders. The adults had higher total scores than the children. In terms of the most severe symptoms, the highest scores were given for stomach fullness, bloating, straining, or squeezing to pass a bowel movement. The most common symptoms on the PAC-SIM were incomplete bowel movements, as well as straining or squeezing. And on the PAGI-SIM, the most common symptoms were fullness, bloating, and noticing that one's stomach looked visibly larger. The next study I'd like to talk about is the PROMISE study. The PROMISE study is a prospective observational study of Trikafta in people with CF over 12 years of age who have at least one copy of the Delta F508 mutation. And in the PROMISE study, as part of the study, they were also looking at pulmonary function and a variety of other outcomes. GI symptom frequency and severity were assessed using the same patient-reported outcome measures as the GALAXY study. In addition to those, stool was collected for calprotectin, which is a really sensitive marker of intestinal inflammation, as well as elastase and steatocrit, which are markers of fat malabsorption. And there's a pediatric PROMISE study, which is also in progress. These data also have not been published yet, but what I can give you are some preliminary findings and some really broad strokes. So after 6 months of Trikafta, all of the GI symptom scores decreased or became less severe, except for bloating and some of the rectal symptoms. However, the differences were small, and even though they were statistically significant, not likely to be very clinically significant. Overall, calprotectin, the inflammation, decreased, but there was no significant change in the markers of fat malabsorption. And so what we can say in a very preliminary way is that after 6 months, the GI symptoms improved slightly, the markers of inflammation decreased, pancreatic insufficiency did not improve. And so despite the beneficial effects of Trikafta on some GI symptoms, these aren't really dramatic changes, and many people continue to have symptoms within 6 months. So knowing that even in the era of highly effective modulator therapy, we still have a long way to go in addressing GI symptoms, the Cystic Fibrosis Foundation developed the DIGEST program, which stands for Developing Innovative Gastroenterology Specialty Training. And this was created to address the growing demand for physicians who are really trained to address the unique digestive and liver needs of individuals who are living with CF, to expand access to care, and to expand the focus on GI in the CF Foundation's clinical research enterprise. The goals of the program were really to define what we know and expand our knowledge base, to become advocates for improving the care that we provide in the realm of GI and liver disease, to improve our patients' access to expert care, develop regional CF, GI, and liver programs, and promote more collaboration between CF centers and local GI divisions or groups. We created a distance-based learning program, and this was even in the era before COVID, when such a thing was really very novel, as well as to develop a best practice document. And to date, there have been 3 classes of DIGEST awardees who are mostly junior faculty in gastroenterology, both pediatric and adult. And this is showing where all of those who are practicing in CF, GI, and liver disease, the awardees and the DIGEST faculty, where they're all located. And you can see that although there are some pockets where it's still pretty far to get to a CF/GI expert, the network is definitely there and it's definitely expanding. Now, you may be asking yourself, what if I don't have a DIGEST person at my CF center? How can I still get access to this type of care? Well, the DIGEST faculty and awardees can serve as resources for other gastroenterologists as well as for care teams. And in fact, DIGEST faculty and awardees have been working hard to spread their expertise to other members of the care team. A lot of this is through publications in the Journal of Cystic Fibrosis, in Pediatric Pulmonology, presentations at NASPGHAN, which is the Pediatric Gastroenterology Professional Society, as well as many sessions at NACFC, including symposia on liver disease, GI symptoms, the GI effects of modulators, a strong collaboration with our dietitian colleagues to run consultation clinics, research workshops, symposia, and then smaller venues for care teams to ask questions, such as lunch and learns. If you're thinking about accessing actual clinical care, there are some tools that are available to you, even if you don't have a DIGEST person at your center. It's possible that there might be someone at a center in your region who would be able to see you for an in-person visit. If not, telemedicine is another option that is expanding in terms of availability. The rules and the payment for telemedicine do vary by state and insurance plans. So if this is something that you're interested in, we encourage you to talk to your care team and in particular to your social worker to see what might be possible. In addition, the CF Foundation is helping to create a visiting professorship where DIGEST awardees can spend time at other institutions and help to share their expertise with care teams. So the network is building, although it's still a work in progress. So to review quickly what we've spoken about, bloating, constipation, and abdominal pain are very common GI symptoms in people who are living with CF, and these symptoms remain despite modulators that are highly effective. PROMs are an important tool for studying these GI symptoms as well as new therapies. And we've built a network of CF gastroenterologists to provide clinical care and conduct research. So next, Dr. Green will speak about what's on the horizon in GI research.
Thank you, Sarah. So today I will talk about GI, where we're going. The objectives today are to quickly review common GI manifestations of CF, to think how modulators might affect GI disease and open up for different treatment options, and to overview active or upcoming research studies. So this is just a quick slide to demonstrate how prevalent CF is in the GI tract, or what it can affect. So we know it can affect the pancreas, it can affect all areas of the intestine, particularly the colon and the small intestine, resulting in obstructions or constipation or dysbiosis, and it can also affect the liver and gallbladder. Abdominal symptoms, as we said, are really common in the CF population. This study looked at 131 CF patients, both adults and pediatrics, and asked sort of what are the most common GI or abdominal complaints. There was frequent complaints of lack of appetite, loss of taste, abdominal pain, as well as flatulence and abdominal distension. All patients complained of one abdominal symptom, at least one, over the 3-month period. So what's on the horizon? There are multiple areas of active research in GI-CF. Motility, as we said, is a popular area for research. So this is how the intestine moves, and there's focus on constipation as well as distal intestinal obstruction syndrome. Bloating, abdominal pain, diet, nutrition, enzyme replacement therapy, and colorectal cancer are also areas of research. So I think I put a poll question out before in terms of how many studies are actually looking or have completed looking at constipation treatments and cystic fibrosis. And sadly, there was only one completed study. So we know there needs to be more effort in this area. Common treatments for constipation are ensuring adequate hydration, ensuring adequate enzyme dose, osmotic laxatives, otherwise known as stool softeners, so things like Miralax, lactulose, even juice or magnesium. And then there are the stimulant laxatives or the squeezers like Senna or Bisacodyl. So Dr. Dhiren Patel is looking at the effect of Miralax on intestinal transit. And this is a small study involving adult patients with CF and constipation. He will assess motility symptoms with a survey at baseline, as well as have these adults swallow a smart pill, a picture of which you can see down there at the bottom. This smart pill will measure intestinal transit time. He will then have these patients go on Miralax, 1 capsule a day for 2 weeks, and then repeat the symptom survey and intestinal transit time with the smart pill to see if there is an improvement in symptoms and or motility. The CFTR modulators perhaps are opening the door for new therapies for constipation. So one such therapy is lubiprostone or Amitiza. This medication uses a type 2 chloride channel in the intestine to promote chloride and fluid secretion and decrease transit time. While it uses a non-CFTR chloride channel, there is thought that it might actually require functional CFTR to induce secretion. There was a small pilot study involving 7 adults with CF and constipation, where they were put on lubiprostone for 4 weeks. They noted improved symptoms of constipation, but spontaneous bowel movements and Bristol stool scales did not change. But perhaps in the era of modulators and improved functioning CFTR, this therapy might be more effective. Another potential therapy is linaclotide or Linzess. This medication acts directly on CFTR to stimulate intestinal fluid secretion through secretion of chloride and bicarbonate. It therefore decreases transit time. In fact, there is actually a recent work by Dr. Sellers at Stanford looking at linaclotide and stimulating duodenal bicarbonate secretion independent of CFTR. This is unpublished work, but it is exciting because it suggests that this medication might also be helpful for those patients who are not eligible for modulator therapy. Distal intestinal obstruction syndrome, or DIOS, refers to complete or partial intestinal obstruction due to accumulation of viscid fecal material in the distal ileum and proximal colon. Unfortunately, risk factors and treatment or management of DIOS are not well defined. In fact, a recent Cochrane review found only one double-blinded randomized crossover trial evaluating the treatment of DIOS, and they concluded that there is just a lack of evidence for the treatment of DIOS in people with CF. I am conducting a linked database study using the CF patient registry as well as FIS, which is a pediatric health information system involving large pediatric hospitals around the country. This study is to better characterize DIOS admissions, risk factors, and management in the CF pediatric population. Another study using MRI to assess GI transit and function is coming out of, or has come out from the UK. The first part of the study was to compare transit time using MRI in cystic fibrosis patients compared to people without CF, so healthy controls. And they found significantly decreased transit time after a meal in those with cystic fibrosis. They then repeated the study with CF patients following tezacaftor, ivacaftor. They didn't find any differences in transit times or colonic volumes compared to placebo after 1 month on Symdeko, but they are now repeating this study with Trikafta, although these results are not yet published. Dr. Christopher Velez at Massachusetts General Hospital is examining GI sensory motor dysfunction using motility testing and GI symptoms using the Galaxy PROMS that Sarah Lussman discussed in CF-related diabetes. As we discussed, abdominal bloating is a really common complaint among the CF population, and Dr. Baha Mashiri is looking at the treatment of rifaximin for management of bloating in cystic fibrosis. This is an exciting study looking at the IB-Stim device. So this is a neurostimulation, and you can see that device placed behind the ear, and it sends electrical impulses. It's non-invasive. It sends electrical impulses to cranial nerve bundles located near the ear. And the idea is to modify pain sensation via the vagus nerve and the pain center. The hope is to improve abdominal pain in CF patients with chronic abdominal pain by targeting the nerves. A few years ago, I decided to look to see if we could improve abdominal symptoms in CF patients by changing the diet. And really the intervention was to remove a lot of processed foods and really focus on good, healthy, quality foods. So what I did was I assessed GI symptoms using surveys, as well as intestinal inflammation using the stool calprotectin, and also collected stool for microbiome. I then asked enrolled participants to go on a diet that removed processed foods for 1 month, and then repeated the symptom surveys, as well as the stool test looking at inflammation and fecal microbiome after 1 month on the diet. This study is completed, but the results have not been published yet or fully analyzed, but hope to be soon. So enzyme replacement therapy, or PERT, has not been updated in many, many years. So there was feedback from Community Voice in response to a question: what do you or does your loved one consider to be the biggest challenge to using PERT? A lot of the complaints or concerns were the number of capsules used per day, the lack of a liquid product. But designing an enzyme is not simple. You need to think that nutrients need to be absorbed only in the small intestine, and especially at the very top of the small intestine. We know pH is important, and stomach acid will destroy enzymes. In addition, people with CF have decreased ability to neutralize stomach acid. Also, people's stomachs empty at different rates, and their intestines move at different rates. So we need the enzymes to remain effective for a different amount of time. So Sinspira Therapeutics has actually developed a new enzyme with these characteristics and is getting ready to start a new clinical study in the US. So this enzyme is manufactured, so it's not from pig pancreases. It's stable in acid. It works as soon as a meal is eaten, but also within a range of time that will work for people with different motility. It seems to be more potent, so only one small tablet will work for a range of meal sizes and snacks. And it seems that it may be available in liquid form. It also improves absorption of all fats, including good fats like omega-3. As we've heard, colorectal cancer is more common in the CF population, and recommendations are that we screen earlier with colonoscopy. This study is looking at the role of non-invasive colorectal cancer evaluation in CF patients. So this involves a FIT stool-based testing. So this study is comparing this FIT stool-based testing to colonoscopy in individuals with CF undergoing colon cancer screening. So my take-home points are that most people with CF experience GI symptoms. CFTR modulators may open the way for certain medications, such as the laxatives that I've discussed, that require functioning CFTR in the GI tract. There is a strong research interest in GI, and I just covered some of the studies that are ongoing. There's particular interest in GI motility and how this may impact symptoms. We're starting to look at diet quality and how this may impact the GI microbiome as well as symptoms. And we are working on improving enzyme replacement therapy, and this was really a direct response to community voice. We know that there is more to do. For example, we need studies focused on pancreatic sufficient CF patients. We know the post-transplant population is a unique group, and we need to think about the causes and treatment of observed increases in their GI symptoms. Finally, we also need to think, why do some experience increased GI symptoms, particularly abdominal pain, after starting Trikafta, and how should we treat these symptoms? But really, we want to hear from you, because a lot of this research is in response to our patients and how we can make their lives better from the GI side. So with that, I would like to hand over to Dr. Daniel Leung to talk about CF liver disease.
Thank you, Nicole. Good evening, everyone, and thanks for spending your Thursday night with us. Over the next 10 minutes or more, I hope to really share with you how biomarkers for cystic fibrosis liver disease have evolved over the years. And my objectives are relatively simple. I'm going to start off with really highlighting why advanced CF liver disease is so clinically important, as well as briefly summarizing some risk factors. As we talk about biomarkers, some of these biomarkers can be used as a screening test, and we want to understand what makes a good screening test. And then we'll take some time reviewing all the components of the hepatic function panel that some of you may be already quite familiar with, and how biomarker indices using components of the hepatic function panel can be used to inform what we know about CF liver disease. And then lastly, we'll close with a review of how imaging has transformed how we can detect and monitor CF liver disease. So what we're really going to focus on is advanced CF liver disease. And I know this picture is not very attractive, but sadly, close to 10% of children in particular will develop this patchy lobular disease within the first decade of life. And nodularity with portal hypertension really is the #3 cause of death in CF. And it's second only to respiratory complications and lung transplant complications. And we know that when your liver becomes lobular and hard and stiff, like the one shown here, that you can have blood vessels engorge with blood in the esophagus and the stomach and the spleen. We also know that GI bleeding can occur in up to 50% of children with CF liver disease. So what are some of the risk factors for developing advanced CF liver disease? Pancreatic insufficiency is definitely one. If you have 2 class 1 through 3 or severe CF mutations, if you're a carrier for SERPIN-A1Z allele, or you have a neonatal history of meconium ileus, those do appear to increase risk. There's also a male predominance in patients who develop CF liver disease. And as I'll show towards the middle of today's presentation, a heterogeneous research ultrasound pattern has also been identified to be associated with a 9-fold increased risk of developing a nodular ultrasound, which we believe to be advanced CF liver disease. So what makes a good biomarker or good screening test? Well, we want our screening test to be able to detect a high proportion of disease, preferentially even before it becomes a serious disease. We want them to be safe and cheap. We'd like a good screening test to be easily accessible, and ultimately we want our biomarkers to lead to improved health outcomes. So here's a hepatic function panel, and here are all the different labs included in that. I think it's really important to sort of empower ourselves with understanding what some of these laboratories mean. The ALT, also known as alanine aminotransferase, is a pretty sensitive marker of liver inflammation. AST is another aminotransferase. It too is a marker of liver inflammation, but it's not quite as sensitive. In fact, if you have a muscular disease, or even if you exercise too much, or you have kidney disease, AST can be falsely elevated. What about GGT? GGT is gamma glutamyl transferase. This really is a marker of biliary or bile duct inflammation, or inflammation within the plumbing of the liver. Alkaline phosphatase. Alkaline phosphatase is used routinely by adult liver physicians as a marker of inflammation within the plumbing of the liver. But in pediatrics, we don't routinely use this, particularly to interpret CF liver disease, because it can be quite elevated from bones in rapidly growing infants and children. And then lastly, albumin. Albumin is actually a protein that the liver produces. And when the albumin is low, it can be due to malnutrition, but it can also be due to poor production from the liver. Now, that was not an exhaustive list. There are some other important blood tests for us to consider as well, and you can see them here. The first is bilirubin. So a conjugated or direct bilirubin really is a lab that, when elevated, suggests that there may be blockage of the plumbing within the liver, or blockage to bile flow. Ammonia is actually a toxin that your liver filters, and when your liver is not working well, your body won't be able to filter all of the ammonia, and the ammonia levels may increase over time. And then PT-INR, that stands for prothrombin time, or international normalized ratio, and these are measures of blood clotting. And we know that elevation of either of these may suggest either liver dysfunction or possibly vitamin K deficiency. And then lastly, platelet count. Platelet count is really not a liver test per se, but in patients with CF liver disease and portal hypertension, if one appreciates a low level or a declining level, even within a normal range, this may be an early marker for evolving advanced CF liver disease with portal hypertension. So how do these components of the hepatic function panel inform the potential development of CF liver disease? Woodruff and colleagues in the figure on the left showed that if you had an AST, ALT, or GGT greater than just 1.5 times the upper limit of normal, that increased your likelihood of developing CF liver disease between 2 times to 6.5 times. Our colleagues in Europe looked at the impact of GGT and what that might tell you. You can see on the very far right in the black box that patients with CF liver disease had a much higher GGT value than CF controls without liver disease. But what's interesting is, even though it was much higher, these levels are technically within normal range according to most laboratories. So these may be early markers of CF liver disease. Platelet count. This was a really nice abstract from the European CF conference in nearly 100 patients. And what you can see here in the green lines is that the overwhelming majority of patients with CF liver disease drop their platelet counts to less than 150 by 10 to 15 years of age, whereas the CF controls with no liver disease up there in the blue don't really drop their platelet counts at all. So these can be quite useful. We're going to switch our focus now to biomarker indices. Biomarker indices actually utilize components of the hepatic function panel to calculate a score. And this particular score, APRI or APRI, has been demonstrated to be associated with liver biopsy validated fibrosis in the setting of CF. In collaboration with our colleagues from Australia, we demonstrated this association. On the left side, I think you can appreciate that an APRI score of 0.264 or more differentiated those who had CF liver disease compared to those who did not have CF liver disease. Now, when you look at the figure on the right, of the patients who had CF liver disease, an APRI score of 0.462 was actually able to distinguish those who had severe fibrosis on liver biopsy compared to those with only mild fibrosis on liver biopsy. So APRI is actually quite useful in the clinical setting and can be calculated on the back of a napkin in clinic. As we talk about biomarkers, we have to talk about imaging. And certainly, if your hepatic function panel labs are abnormal for more than 6 months, grayscale ultrasound really is sort of the first step used to detect different patterns of CF liver disease. And our CF liver disease network has studied this. Here on the right, you can see what a normal ultrasound pattern might look like. On the right is a heterogeneous or patchy bright ultrasound. On the bottom left is a nodular or lumpy bumpy ultrasound. And on the bottom right is a homogeneous, smooth, and bright ultrasound. And what the CF Liver Disease Network found out unknowingly to us is that 18% of children with pancreatic insufficiency in CF who had no known liver disease actually had an abnormal ultrasound pattern. And the hypothesis was that the heterogeneous or patchy pattern may increase your risk for developing a nodular pattern. And that's exactly what this long-term follow-up study eventually showed, is that in a research setting, a heterogeneous or patchy ultrasound predicts a high likelihood of developing advanced CF liver disease. And in the first yellow box there, I think you can appreciate that a much larger proportion of patients with a heterogeneous or patchy ultrasound developed a nodular ultrasound compared to those who started off with just a normal ultrasound. In fact, this conferred a 9.3 higher risk of developing nodular liver disease in the future. The CF Liver Disease Network has been an amazing collaboration between the NIH and the CF Foundation and has been led by our lead investigator, Michael Narkowitz. And we've looked not only at grayscale ultrasound, but a variety of different imaging biomarkers, as well as some of the biomarker indices that I've already reviewed. And in this very colorful violin plot, I hope you can appreciate that as patients go from a normal ultrasound to a heterogeneous ultrasound to the purple nodular ultrasound, that the platelet count appears to drop. And this is in stark contrast to the violin plot on the very bottom, in which patients with a normal ultrasound have the lowest APRI, whereas patients with a nodular ultrasound have the highest APRI. Again, showing that these may be quite helpful to look at over time. We're going to close with talking about liver elastography. Liver elastography comes in two different forms. On the left is transient elastography or FibroScan, which uses ultrasound technology. And on the right is MRI, which uses magnet technology. Elastography measures liver stiffness. And so why is this relevant to the liver? Well, I'm going to just ask a very brief question. When you think of a block of Jell-O versus a block of steel, do you think that a vibration would travel faster through the block of Jell-O or through the block of steel? Well, if you answered the block of steel, you're right, because the harder or stiffer an object is, it allows conduction of vibration much faster. And so here's the patient experience for transient elastography on the left. This can be done at the bedside by a clinician or any health provider. It's non-invasive. It provides a one-dimensional image. And there in the orange box, you can see that it calculates a liver stiffness measurement in kilopascals. The experience with MR elastography is quite different. This requires a radiology technician performed in a radiology suite. It can be a little claustrophobic and is a little more expensive than the FibroScan. But the MRE provides some very interesting information. Using an active driver, which transmits vibrations to a passive driver, you can see that white little passive driver, that sits right on top of the liver. And as the patient goes through the MRI tunnel, it creates a heat map. And what the heat map tells us is that the warmer the colors, yellow, orange, red, the stiffer your liver is, and it provides anatomic information. Well, these 11 studies demonstrate and sort of confirm that transient elastography or FibroScan is able to differentiate those with advanced CF liver disease, shown there in green, from those who don't have liver disease. And many of these studies also show a difference between just having elevated liver enzymes or CF liver disease compared to those with advanced CF liver disease, showing its clinical utility. This study shows that transient elastography can be monitored over time and may be a non-invasive way that's quite helpful to providers. And I'll just sort of draw your eyes to the select patients shown there in red. They started off as having no liver disease with very low stiffness, but by 10 to 11 years of age, their liver stiffness increased and surpassed the normal thresholds. Again, demonstrating that transient elastography can be followed over time. And then the last thing I want to just mention is some unpublished data from Alex Tobin within our CF Liver Disease Network, demonstrating that MR elastography in cystic fibrosis is quite feasible. In fact, 83 out of 97 participants successfully completed their scans, although these patients were a bit older in their mid-teenage years. And what you can see there on the right is that MR elastography demonstrated significantly increased liver stiffness in those who had a nodular ultrasound pattern. And similarly, on the bottom right, patients with a nodular ultrasound pattern had a much larger spleen diameter on MRI as well. So in conclusion, having a severe class 1 through 3 mutation, being a carrier for the SERPINA1Z allele, or perhaps having a patchy ultrasound may be viewed as risk factors for advanced CF liver disease. And I think we would be quite naive to think that a single test would be superior to others. It's really going to be a combination of blood work, biomarkers, imaging with your physician's exam that is going to inform the best clinical next steps. Ultrasound and ultrasound elastography really are the most readily available imaging modalities right now that seem to be the most effective to screen for CF, but MR elastography is definitely coming to a theater near you and is eventually going to become more affordable and more accessible over time. Thanks so much for your attention. Really appreciate it.
Thank you, Dr. Leon, for that. Before we get to your questions, I wanted to share with you 3 things I've learned from my experience as a caregiver. Being able to communicate effectively with our social worker positively impacted my ability to advocate for my boys. During a frustrating admission for Grayson, our social worker reached out to me via email, and in response, I was able to share my concerns. She could sense my desperation, and she was able to take my frustrations and relay them to our care team on our behalf. We were then able to come up with a plan for the next time that would streamline Grayson's admissions, noting he has GI complication, who needs to be contacted, and what treatment plan needs to be executed. Because I was able to share my fears and concerns with her, she was able to help me come up with a better, more permanent solution for the future. Speaking with a mental health expert improved my mental health and aided in my ability to advocate and care for my boys. In the beginning of our journey, I feared being one of those moms. I wanted to advocate for my boys, but I didn't want to be confrontational or come off as aggressive. Connecting with a counselor allowed me to talk through my worries while developing coping strategies to decrease my anxiety. I was able to develop effective communication techniques so that I could better advocate for Mason and Grayson. Lastly, I learned that the doctors don't have all the answers. Being a nurse, I technically knew this. Once I had medically complex children, all my nursing knowledge vanished. I just wanted someone to fix my babies. It wasn't until Grayson started experiencing all his complications that I realized how little research there was on GI complications in CF. During a GI appointment with Dr. Friedman, he was very honest and reminded us that Grayson's complications aren't typical, and he didn't know how to help Grayson. But despite not having answers, he wasn't going to stop trying. That was all I needed. I needed honesty and to know that we weren't alone on this journey. The past 7 years have taught me a lot. I have learned a lot about myself, what I'm capable of, and that my heroes are some pretty cool little dudes. Though it has been a struggle, I have learned the importance of speaking up. Whether you're a person with CF, parent of a child with CF, or a caregiver, you are an essential component of your care team. Your team doesn't exist without you. Your concerns deserve to be heard, even if it means becoming the squeaky wheel, respectfully, until your questions are answered. I hope that what I have learned and shared with you today can help you all become better advocates for yourselves or for your loved one with CF. I hope that healthcare professionals understand the importance of establishing a connection built on honesty and dedication while remembering to really listen to your patient's concerns. I truly appreciate the opportunity to share our story alongside Dr. Freeman. Now we'll dive into your questions.
Once again, Amanda, thank you so much. And thank you to all of our speakers. We're going to have a little over 10 minutes here for questions. We have a lot of common topics, and so we'll be asking questions maybe more broadly than they were specifically phrased, but we're going to do our best to tackle as many of these subjects as we possibly can. We'll start with Dr. Lustman. So the question is, what terms do you hear mostly from children to describe a full bowel? If all they've ever known is constipation, how do we really allow them to recognize this before they get completely backed up? And somewhat related to that, is there utility in a routine abdominal x-ray yearly or any interval similar to getting a chest x-ray?
Thanks. Those are both great questions. So I think that the most important thing, both for children and adults, is to really, first of all, get comfortable describing your stool. You may not think that the doctors want to know all of this detail, but we really do. And it's really helpful for you to be very descriptive. There are some standardized measures and terms that are used. There's something called the Bristol Stool Scale, which you can easily find online, and you may actually see a doctor pulling it up during a visit and asking you what your stools look like, which type. So that can be a useful way. Also, trying to track your stools if you are experiencing some issues with diarrhea, constipation, bloating, abdominal pain. Trying to track your stools for a period of time before the appointment can be very helpful. It's often easier to make a note in your phone or jot down on a piece of paper how many times a day you're passing stool or having a bowel movement and what the consistency looks like. Then you can bring that data to your appointment as you plan for the visit, rather than trying to recall as you're sitting there in the doctor's office. So those two things I think are really important tools. And then, so we don't want to necessarily put it on the child to realize when they're backed up, but I think sometimes just gathering some data can be very helpful. In terms of the question about an x-ray, I think that an x-ray can sometimes be helpful in the situation that I referred to in the talk, when there is frequent or loose stool, but we suspect that there may actually be a lot of retained stool in there. So sometimes I will order an x-ray just to get a sense of whether I need to be more aggressive or less aggressive with laxatives at the time of the visit. But it's important to remember a couple of things about x-rays. One is that they are a snapshot in time, so they'll tell you how much stool is in there on any one particular day, but not necessarily useful on a routine basis for screening. They also can be very subjective. If you show the same x-ray to a few different radiologists, you might get a few different opinions over whether there's a little bit, a moderate amount, a lot of stool in there. So it's important to really look at the images, not just the report of what's there, and to try to see if that indicates any change in therapy.
Thank you, Dr. Lustman. Dr. Green, there is quite a few questions on probiotics. I'm going to leave it a little bit more general, but questions, related to what's the right type, is there a different probiotic given what CF manifestation they're having, and anything specific for gastroparesis?
Yeah, so I get questions about probiotics a lot, and I think, to be completely upfront, there isn't convincing evidence that they make a ton of difference for a lot of people. But then again, some people swear by them. But in terms of the research out there, the stuff on probiotics isn't convincing. Again, it's not harmful. Some people it may help, but I typically don't just recommend routine probiotics in all my CF patients, because I think environment in general that the GI tract sees is important as a whole. So, what we eat, antibiotics, if you take a course of antibiotics, that's going to overwhelm any sort of microbiome, bacterial or probiotics. So I think if they help you, great. But if it's just an extra medication that doesn't seem to be doing anything for you, then I don't feel strongly about probiotics based on the data that we have.
Thank you, Dr. Green. Dr. Leung, is there any research being done that could lead to treatments for CF liver disease?
Yeah, thanks, Amanda. I think Dr. Lustman may have mentioned the PROMISE study, right? Looking at highly effective modulators before and after treatment. And while CFTR modulators may not specifically address risk for developing CF liver disease, there certainly is optimism that restoration of CFTR within the plumbing of the liver is going to result in better bile flow in the liver, reducing the likelihood of liver disease. And so we're actually doing the same study in younger children, 3 years and older, called BEGIN. So I think the jury will still be out. I think we'll probably need 6 to 8 years to know if CFTR modulators are going to change the natural history of liver disease. Other than that, the CF Liver Disease Network has been working hard over the last few years, designing a clinical trial for patients with CF liver disease, demonstrating its safety and efficacy. And I'm hopeful that soon we'll be able to provide you a little more detail, but a lot of effort and time across a variety of centers has gone into that with the help of the CF Foundation and the NIH.
Thank you, Dr. Leung. I know there was some questions about how do you know if probiotics were working or not. Maybe we'll be able to tackle that a little bit in the evening session, because I do want to get to a couple of other topics. Dr. Lustman, there's quite a few questions on, are there a list of digest physicians? Are they predominantly peds or are they adult? And if they need this type of expertise, how do they find these doctors?
Sure. So the Digest program has now been through 3 iterations or 3 classes of awardees, and each class had between 15 and 20 awardees who were trained, as well as the handful of faculty who carried on mostly through the 3 classes. And the first group started in 2014, underwent a 3-year program. The second group, I believe, in 2016, and the third group started in 2019. And the program consisted of some in-person meetings, attendance at NACFC, a day of introductory meetings, as well as monthly webinars, which were educational, including important topics in CF, as well as case presentations, as well as many sub-projects, such as the best practice guideline that were being worked on with the Digest awardees and the faculty mentors. And since the paper came out describing the development of the Digest program, I have been contacted by some patients, families who came across the article, as well as doctors at other centers, either looking to refer patients to me directly or asking for a recommendation for someone in their region. And we have been able to connect people. I know also some people have contacted the CF Foundation directly to find the name of someone who's in their region. The awardees, as you saw on the map, are pretty much all over the country. They're about 60% pediatrics and 40% adults. And I think that judging from these questions, we can work with representatives from the foundation to figure out the best way to communicate and publicize the list of faculty in a way that's accessible to families.
All right, Dr. Green, are there any dietary changes for patients on Trikafta or other modulators?
Yeah, so there aren't any official dietary changes that we recommend, but I think what a lot of us have observed, which is great for some people and not so great for others, is that there is significant weight gain in a lot of people after starting some of the modulators. And we think this is largely due to better intestinal absorption. So I think for some people that's great if they've been underweight, but some people that becomes, we're seeing more of overweight CF patients or even in the obese category. So I just like to focus on, I think historically the focus on diet and nutrition in CF has been sort of quantity of calories and high fat. And I just like to focus a little bit more on the quality of those calories, especially if we're seeing larger weight gain. So just more nutritious, filling foods, trying to limit the highly processed sort of chips, cookies, sodas, just recommendations for healthy diet. Because we have seen in other GI inflammatory conditions outside of cystic fibrosis that diet can be important, and potentially some food additives could be somewhat disruptive to the GI intestinal mucosa. So I think food can be medicine too. I wouldn't change someone's diet completely, but just trying to focus on quality, especially if weight is a concern or they're having lots of GI symptoms.
All right. Well, I know there's going to be a lot of questions we're not able to get to. Hopefully we can address some of those between Amanda and I later, but we do want to have one more question for Dr. Leung. There's a question regarding elastography and ultrasound. Should these modalities be used annually? Should they be done twice a year? How frequently should they be assessed to monitor CF liver disease? And then to piggyback off that, are there any medications you recommend or things that should not be used for the treatment of CFLD?
Yeah, thanks, Jay. Well, definitely stay tuned. The CF Foundation is coming out with some liver guidelines, and I'll be very curious to know what that recommendation is. I can tell you from my experience and from our work is that elastography appears to be a helpful tool, but the thresholds of liver stiffness generally in the literature have sort of been set at 7, but I wouldn't say that elastography has yet been the ubiquitous standard of care. I personally feel as though it's going to be quite helpful. Ultimately, I think your physician's hands are going to provide a lot of information as we measure your spleen size, as we sort of review your platelet counts and determine if there's a drop or not. Certainly, if there is a discrete lesion or a nodule that you've not seen before, yes, I would recommend an ultrasound every 6 months with an AFP. There's not a whole lot of literature on the risk of liver cancer in patients with CF liver disease, but theoretically, there may be higher risk.
Excellent. And any medications that you think patients that are concerned about liver disease should try, or anything they should stay away from?
Well, I can answer the latter. Obviously, you want to be careful with cough syrups that have a high alcohol content. You want to avoid alcohol as much as possible. We know that binge drinking will definitely result in significant fat within the liver. What we don't know is if fat in the liver affects patients with CF the same way that it does in patients without CF. But that being said, I would take the more conservative route and do one's best to avoid any excessive alcohol consumption.
Wonderful. I think that's helpful and touches on another question somebody had asked about alcohol use, but we'll be happy to expand on that. Well, Doctors Green, Lussman, Leung, thank you guys so much for your wonderful talks and your insight. To end the session, I'm going to turn this back over to our parent expert, the real expert in the room, Amanda, to close us out here.
We are just about out of time, so I want to wrap up. Before we close, we want to draw your attention to some ways that you can be involved in upcoming GI projects. Community Voice comprises people from across the CF community to bring their unique insights and priorities to the forefront of research, care, and programs. When you join Community Voice, you receive tailored opportunities catered to your interests, from answering surveys to joining committees that you can do from the comfort of your own home when you have time. We have put the Community Voice link in the chat, so feel free to learn more there and sign up to provide your feedback. Thank you to all our speakers for sharing your knowledge and insight about Listen to Your Gut, and thanks to all of you for your attention and your questions. There are many wonderful resources related to this discussion in the resource document found on the reception page. For this session, you'll find the slides we shared and other items the speakers thought you might find valuable. Please spend some time exploring the resources and download anything that you want to keep. We now have expo booths and networking sessions open for the next 45 minutes. In the expo, you can visit CF Foundation staff to learn about several foundation research initiatives or visit one of the 2 Meet the Speaker booths where you can casually interact with Dr. Greg Zawicki and Shelby Lubert from the opening keynote, or Dr. Jay Freeman and me. If you are more interested in meeting other ResearchCon attendees, visit the networking tab, which is a fun feature that allows you to connect with others and get randomly matched with another attendee for a 5-minute video conversation. This attendee could be a clinician, CF community member, researcher, or CF Foundation staff member. You never know who you'll get matched with. After the networking and expo booths, we hope to see you at 12:45 p.m. Eastern Standard Time on Saturday, April 9th for day 2 of ResearchCon. Thanks again for coming to learn about GI and Listen to Your Gut.